malignancy, and preoperative planning should also involve multidisciplinary discussion, especially in cases where malignancy is suspected, to ensure appropriate oncologic expertise post-surgical care. The goal is to do a meticulous planning to minimize the complication, to ensure a complete resection, and tailor the procedure to meet the individual need of a patient. Today's orator, Dr. Nija Batla, who is also Vice President of uh, Foxy, VP Foxy 2024, President of AGOI 2014 and 15, and also ex-HOD of All India Institute of Medical Sciences, Delhi, will delve deeper into all the discussion. And we have with us to chair the session Dr. Sarita and Dr. Sujita. Both I have been vice presidents from 2015. Dr. Anjana Chauhan, who is herself also a gynae and oncologist, Dr. Shubha and Dr. Priyanka. They are the coordinators who have worked day and night to throw the, to work, bring in everything together. So over to the chairpersons, please, to take over the session.
Thank you, Madam.
Dr. Anjana would invite
Yes.
the chairpersons first.
Yes.
I would request Dr. Anjana to invite the chair. Yeah.
Thank you, ma'am. And a wonderful madam is always with beautiful sari and very nice necklaces, Dr. Anju, sorry. And now I invite both the chairperson, Dr. Sujata Mishra. She is the director of Postgraduate Institute of Medical Science and Research, Bhubaneswar, and at present VP Foxy 2000. She was a VP Foxy 2015. Dr. Sarita Agrawal. She is the HOD of Carer Hospital. She is a vice president of Bhopal Obstetric and Gynec Society and executive committee member of IMS. Please, chairpersons, I hand over the mic to you for introduction and to carry on the session. Thank you.
Okay, so can I come in?
Yes,
good evening, everybody. It's without wasting any time, we've listened to all the introductions. I would definitely like to spend a moment to catch up the lovely times I've spent with Dr. Nija Bhatla in several AGOIs, and I really look forward. I mean, describing her, I would feel short of words. And as a VP also, she's doing excellent. Even prior to that, she's been doing a lot of things in AGOI. We've met in meetings. So over to you, Dr. Nija Bhatla, to start your proceedings, unless Dr. Sarita wants to say something. Thank you.
Welcome, madam. It's a very nice meeting from all of you, and you can proceed our session.
Welcome, Dr. Nija.
So very much. It's so nice to be here today. Thank you, Dr. Anju, Dr. Shubha, for your kind invitation, introduction. And Dr. Anjana, yes, I can see she's been very active putting flyers on all the groups. It's wonderful to see Dr. Sujata after a bit of a gap this time. And Dr. Sarita also. And I must give a little disclaimer. I've been down with a viral, so you will excuse me if I have little bouts of coughing or anything. This is a good part of webinar that we can come on without risk of infection to anybody else. So I thought I should not change the date just because of little cough and cold, and I should be with you today. So yes, as we know it, it is one moment, just let me get my screen in order. It is September, it is very interesting that it depends where you are. And it is in UK, it is the Gynecological Cancer Awareness Month. Can you see my screen now?
Yes, ma'am. Yes.
Yes.
It is, yeah.
It is the Gynecological Cancer Awareness Month, but in general, we have been knowing it as the Ovarian Cancer Awareness Month, and therefore this topic becomes even more interesting and important in this context. So very nicely summarized by Dr. Anju. I think she gave a full summary of the whole thing, and the goal of pre-surgical planning is that you can thereby have the appropriate management and diagnosis, because the accurate diagnosis is pre-operatively will help us to plan the surgery and to be sure what surgery we are doing, how much we are going to do. And this is important not only to get the informed consent from the patient, because really we cannot do more than we took the consent, but it is also important because this complete resection has become clearly the requirement that we should be able to do a complete or move to the NACT. So we should know in advance, as far as possible, the accurate diagnosis. And it is also always keeping in mind the patient safety and comfort. We want the complete healing and the quick healing, a rapid recovery, because if it is a malignant tumor, it is really important that we start the chemotherapy in due course. It has been shown to have prognostic impact if the chemotherapy gets delayed because there was infection or some problem. So today we'll have a little bit overview on all these aspects. I don't know if this banner is coming in your way or not, but I don't know also what to do with it. So we will look at the introduction, epidemiology, anatomy, differential diagnosis, history, examination, imaging modalities, lab tests, risk assessment models, surgical planning, guidelines, and recommendations, and run through all of these briefly. So differential diagnosis of the ovarian mass depends on several factors. This is one situation which you see right from adolescence up to menopause. So depending on the age, of course, we know that certain tumors will be more common at certain age. The reproductive status will also help, also be important to decide what type of management we are doing, conservative, radical, and there is indeed provision for being conservative in many situations. The clinical features help us in many ways to decide. We have the benign, the malignant, and actually also the borderline, which are becoming quite important now. But in ovarian cancers, we can also have the non-gynecologic causes as well as the metastasis from other sides, which we have to keep in mind. So broadly, if you look at the ovarian masses that you get, the benign pathologies are 2/3 and malignant are 1/3. And in the postmenopausal females, about 1/3 of them will be malignant. So the prevalence in the premenopausal is 1 in 1,000. Age of 50, it goes up to 3 in 1,000, with the proportion varying with age from 1.6% right up to 47.1%. And see how complicated we have this little organ, ovary, 3 centimeter by 2 centimeter by 1 centimeter. Conventionally, we have described the normal size of the ovary, but it has a surface epithelium. It has the serous nature, the sex pod stromal, which has the granulosa cell and early Leydig cell tumors. Then you have the germ cell tumors, the dysgerminoma, yolk sac, immature teratomas. Then you have other things like the inclusion cysts, which will give rise to huge and large mucinous cyst adenomas. Endometriosis, the increasing problem, long-standing, we can see here endometrioid clear cell carcinomas. Both types are seen. And the fallopian tube, which is increasingly the subject of not so much of debate anymore. We accept that the serous carcinomas likely arise from the fallopian tubes and are actually a metastasis in the ovary. And the role of prophylactic salpingectomy has therefore almost become a rule everywhere. So, depending on the symptoms, you will be able to have some possible etiology in your mind. When the patient presents in reproductive age, acute onset pelvic pain, many of these are on anticoagulants, heart disease patients, valve replacement patients, you can have the possibility that the hemorrhagic cyst. Ectopic, we know the classic triad of amenorrhea, bleeding, and pain, and they may even manifest in shock. Ovarian torsion is likely if there's a unilateral, intermittent, and then acutely worsening pelvic pain. If there are fever, chills, vomiting, vaginal discharge, it could be a tubo-ovarian abscess. In some cases, it could be an underlying tuberculosis with a superimposed other bacterial infection. Endometrioma, if it's associated with dysmenorrhea and dyspareunia. abnormal uterine bleeding, even in the reproductive age group, could be estrogen producing ovarian tumors. But when they come in the postmenopausal age group, then it is a more dramatic presentation. And malignancy being the one we'll just come to, but where you have the non-specific symptoms of bloating, generalized abdominal pain, early satiety, could be the symptoms of malignancy. So in this case, you know, the Goff symptom index is important, which has been mentioned many times, because earlier we used to say that ovarian cancer is a silent cancer. Now we say, no, it is not silent, it whispers. If there is a lady over the age of 50 and she is having any of these symptoms onset less than 1 year, more than 12 times a month, pelvic pain, abdominal pain, increasing abdominal size, bloating, difficulty in eating, fullness, pay attention to these symptoms. Don't dismiss them as sometimes patients think we're just imagining. Sometimes they think, oh, we've been eating out too much, all kinds of things. But no, they could be, and they need to be evaluated. And probably an ultrasound is to be advised on a regular basis for all the older age group women. So examination must take into account the general condition, including, of course, the ECOG performance status, the BMI, etc. Because you have to see what surgeries you are planning, and you have to see that the patient is going to be fit to tolerate and recover out of it. So lymphadenopathy, virilization in the sex cord tumors, any extra abdominal features, and the abdominal and pelvic examination. So if the size is large, it is sometimes, as I said, just a benign mucinous cyst adenoma. But if it is an irregular and the mobility is restricted, then it is suspicious. Tenderness could be a mark of endometriosis or infection. The features of malignancy usually are that there is irregular and fixed mass, there's association of ascites, there's posterior cul-de-sac nodularity, and bilaterality also is more often a feature of malignancy. And nowadays, everybody has ultrasound handy. It has become an extension of the examining finger. And transvaginal sonography is the single most effective way of evaluating adnexal mass. And a lot of this we can see ourselves also. The size, the architecture, is it solid or cystic, unilocular, multilocular, a wall thickness, septation, papillary projection, vascularity, and also the ascites. The transabdominal is a supplementary to the TVS, especially when the mass extends beyond the TVS view, but also, of course, if we had to evaluate some abdominal nodes, etc., some amount of information does come through. And for the standardization of the ultrasound reporting, we have had various systems being used, including the IOTA, RMI, the IRADS, and the ORAD system, and we'll see about those in a little while. But meanwhile, just let us see some differential diagnosis that emerges when we see these. So if the radiological appearances of cystic lesions with or without the thin septations, in these patients, usually the CA125 will be normal, and most of them will be benign. The age group for if they are reproductive age would be a follicular cyst. But at any age, you can see the serous or mucinous cyst adenoma, hydrosalpinx, paraovarian or paratubal cyst, peritoneal inclusion cyst, and of course the PCOS, it can be manifested. And the peritoneal inclusion cyst is a very important and not infrequent problem which is associated with previous surgery. And this is very troublesome for the patient. And if it is present, the repeat surgery is not really going to help. And I've had the patients whom we just, we call them back 2 or 3 times, having figured this out. Once we just do an aspiration ultrasound guided every year, once just drain it out, and then eventually it does stop collecting, although people have described putting in glue and all, but we've never done that. And then coming to those where you see the solid lesions, and that could be a leiomyoma or a fibroma. Fibromas are most often in the postmenopausal, and in 10 to 15% of cases, they could have ascites causing what we call the Meek syndrome. And then the CA125 could be elevated. The thecomas are benign postmenopausal. These are estrogen secreting. So also are the granulosa cell tumors, which may be juvenile or adult. These are malignant and they have a very distinctive marker, which is inhibin. So in addition to CA125, they could have inhibin. And inhibin could also be there in the sertoli Leydig cell tumor, which of course will have signs of virilization, or if it could even be estrogen excess. And in the sertoli cell tumors, you might get the production of renin. In the sertoli Leydig cell tumor, you may get the production of testosterone and AFP in addition to inhibin and CA125. And then you have the sex cord tumors, which may be sporadic or associated with the Peutz-Jeghers syndrome. Peutz-Jeghers syndrome, it's very interesting that they sometimes have this mucosal discoloration just inside the mouth. So you must evert out the lip and look inside, because you might find pigmentation there, which will alert you that this is the case of Peutz-Jeghers syndrome. And then you have the Brenner tumor. They are relatively rare of epithelioid origin. These could also sometimes be associated with Meek. They could be benign or borderline or malignant, usually coming in the postmenopausal. The luteoma is peculiarly with the pregnancy. It's benign, but you can get some virilization with it and a spontaneous involution after the delivery. Now, if they're solid, come cystic. They could be corpus luteum cyst. They could be ectopic. I'm not going to go into that discussion. That's a separate discussion in itself. Endometriomas, TO abscesses, mature cystic teratoma, which are very common in the reproductive age, the dermoids. And in fact, in pregnancy, these are the commonest tumors, which can also be bilateral in 10% cases. And then you can have the monodermal teratomas, like you have the struma ovarii, carcinoids, etc. The borderline tumors could be mucinous or serous or endometrioid. They can occur at any age. The laboratory markers are there. CA19-9 also we see with the mucinous tumors. And mostly they are unilateral and they have a relatively better prognosis, and conservative surgery is possible. Although the recurrence rates are higher when the conservative surgery is done, but it is very much feasible. And the malignant germ cell tumors, now this is very important to note, these ones occur in young adults. Fertility is usually a concern and it can be provided. Even in stage 3 tumors, fertility is possible because fertility sparing is possible because they are very chemosensitive. So you can remove the tumor, give them chemotherapy, and we have published large series of patients who have conceived after the chemotherapy and had completely normal babies. And then you have the solid cystic malignant epithelial lesions, which is the whole gamut of types. And the laboratory marker, which is common, is CA125. Now we have also HE4. And then in the mucinous, the CA19-9 CEA, as I said, is present. Now, the risk of malignancy index, this is the one which we talk most commonly about when we have to talk about a situation where patient has presented at a center which is not usually doing cancer surgery. And it's very important at this point to apply this risk of malignancy index to decide either you are doing it in your own small center or you are going to do it in your own small center, inviting to be present in anticipation a surgeon who has the competency, that may be a gynae oncologist or a surgical oncologist if you don't have, whoever you have access, or you will just refer the patient to a center where it can be done appropriately. This is very, very useful index to give a good pointer. For this, it's very simple. It's a formula of CA125 levels, the ultrasound points that you score, and the menopausal status. And as you can see from these pictures, it is not difficult for anybody to see this and to know whether it's uni or multilocular, whether it has solid areas, whether there are any deposits in the abdomen, whether there is presence of ascites, and whether it is unilateral or bilateral. So accordingly, they get the ultrasound scoring done. If there is 1 point, no feature, 1 feature, or 2 or more features, whether they are premenopausal or postmenopausal, just look at the first column of RMI1 and you assign the score. And what is the size of the tumor is used only in RMI4. So for the first one, it is just looking at the ultrasound score, the menopausal status, and the CA125 level. And this is the one which is the most commonly used. Then they tried making modifications of this in the hope of making it more specific by changing the scoring and all that. But they found that RMI1 remained the best with the highest area under curve among the four. RMI1 had the highest specificity, RMI2 had the highest sensitivity, but overall RMI1 was the best performing for differentiation even of the borderline ovarian tumors from the benign ovarian tumors. So let me just go back once to show this formula. This is very important. The CA125 level multiplied by ultrasound point multiplied by menopausal status. And if the cutoff is more than 200, then it is something where you have to be concerned whether she will be able to get the adequate surgery, because the first surgery is always the best surgery. Now there are IOTA rules, and these are the simple rules are malignant features and benign features. So in the malignant features, you can see the irregular solid tumor, presence of ascites more than equal to 4 papillary projections, the irregular multilocular solid tumor more than equal to 10 centimeter, color score 4 if there is a strong blood flow. And the benign features are unilocular cyst, the tumor with the largest solid component less than 7 mm, acoustic shadows, smooth multilocular tumor less than 100 mm, and the color score 1, which means that there is no blood flow. So if there's only the M features, that's malignant, only the B features, that's benign. But if there are both or there are none, then it is the inconclusive. So the simple rules risk calculator made this model based on the 10 features, and the type of center is also there, which means it's at an oncology center or the other center. And I've already elaborated how it makes a difference to the patient's outcome in case she has a malignancy that she's dealt with right away by a trained hand. Now, this gives a predicted risk in percentage of a pathology being either malignant or benign. So the variables are age, ascites, these ultrasound features, a history of ovarian cancer, current hormonal therapy, pain during examination, maximum dia, purely solid, color stroke. So in the LR1 model, there are 12 variables. The LR2 model has 6 variables, and they give a good balance of sensitivity and specificity. And then they came up with the IOTA ADNEX model for assessment of different neoplasia and the ADNEXA. It's a free web application and mathematical algorithm with 9 predictors. There are 3 clinical variables, age, CA125 type of center. Ye dekhiye it is coming again and again, type of center. It impacts the prognosis. Ultrasound variables, the ones we have already been talking, so I'm not reading them out again. And so this IOTA ADNEX model differentiates between the subtype of malignant masses. The score can be calculated with or without the CA125. Sensitivity has been reported as high as 100%, specificity 82%. And you get this patient-specific risk, relative risk, and baseline risk of the chance of benign, the risk of malignancy, and then furthermore, the risk of being borderline stage 1, stage 2 to 4, or metastatic cancer. And you can see, so you can get by the scoring of this age, patient at 53, she is at an oncology center, the maximal dias, that they're not present, papillations, and all, and CA125. And it says 87.3% is the risk, and chances are that it is stage 2 to 4. So there are various studies that have been done to estimate the risk of the malignancy, and these have found that it was the IOTA simple rules was a good one, and they found good sensitivity with ADNEX. Then you have other modalities of imaging, which are also reasonably well available in most of the tertiary centers now, which is 3D ultrasound and Doppler. And we are using these, of course, also for the fetal medicine cases nowadays. And here, again, the 3D powered Doppler angiography helps map the vessel morphology. And so you can get better detection of the central blood vessels. The combination of TVS with powered Doppler flow mapping is for complex cases, not to be done routinely. But because the 3D ultrasound does not necessarily improve diagnosis of complex ovarian cysts, it's not something routinely used in assessment of the adnexal mass. Then in 2009, the system of GI RADS was proposed, I should say, gynecologic imaging reporting and data system to remove the ambiguity in TVS reporting of adnexal masses, classifying the lesion according to level of suspicion and a sensitivity and specificity of 92 and 97%. So specificity high is very, very good because it means there is accurate chance that you have detected the malignancy. And so it gives you 5 grades, starting from definitive benign to going to very probably malignant, where the probability of malignancy goes from 0%, goes high up to more than 20%. And the descriptors have been described. So, so this system is one. And then you have the ORADs. And here they have put the major categories as the physiologic, like the follicular and corpus luteum. And then furthermore, they have divided again based on these various parameters. We had a study at AIIMS. This was the thesis of Shagun Kapoor, and Seema Singhal was her guide. And it was an observational study of 80 patients, and all these 4 ultrasound based system reporting systems were analyzed. And we found in this study, I think this is, hiding the, it's gone the other way. Instead of having this one, I should, just move this. Itna aasan nahi hai dikhana. Anyway, you just have to believe me that the IOTA simple rules, the IRADs and ORADs, they had excellent sensitivity and were found to be suitable as initial screening tool. All 4 were similar for diagnosing the malignant, but the adnexal mass, adnex model, we found it had higher specificity. So if there was inconclusive of the IRADs and ORADs, then that was resolved by the adnex model. Tumor markers, so many are there, and we are using routinely, you know that. Now, they have diagnostic importance as well as then later in disease monitoring and treatment response assessment. So CA125, 15-3, 19-9, HG4, HCG, alpha, AFP, LDH, and inhibin. In fact, germ cell tumors, if we may say, and you know that HCG, FP, LDH is very important, but up to the age of 40, every woman should be suspected that she could be either epithelial or germ cell. HG4 came along, and this combined with CA125 improves the sensitivity and specificity, particularly in early stage. And now novel markers are emerging, microRNAs, DNA methylation pattern, and circulating tumor cell CTCs. And these give you enhanced diagnostic accuracy and scope for personalized management. So eventually, these will also probably become a comprehensive panel to improve the sensitivity and specificity. But you need a careful interpretation. You have to consider the age, menopausal status, and comorbidities as well. CA125, which came in 1981, is one of the most widely studied, most widely used one. I'm not going to go into much detail about its origins and all that, really speaking. Reference value of 35 CA125 that we use, we don't really use the CA125-2. And this is the situation that it actually starts being expressed in the fetal life itself and then gets re-expressed in the neoplasias. The important thing to know is that CA125 is not specific for ovarian cancer. It can be elevated in a multitude of conditions, and here the importance of the clinicians using their discretion is so important, and keeping their mind open to options is so important, and reassuring the patient in case you think it might be something else, because there is a very overlapping range. So gynec malignancies, of course, we've talked about the 3 main: epithelial, fallopian tube, and primary peritoneal, which go hand in hand. But endometrial cancer, once it is a spread, it is also going to raise the CA125. Amongst benign gynec diseases, you know that endometriosis, you see it regularly. It is elevating the CA125, but anything which is raising the which is causing ascites and irritating the peritoneum, Meek syndrome, OHSS, PID, even in pregnancy, and tuberculosis. Among the benign non-gynecologic, the most important mimics the ovarian cancer, even clinically, even on opening abdomen. Be cautious. What looks like a disseminated malignancy may actually be a miliary tuberculosis. And when in doubt, and especially in young patients, do not hesitate to get the frozen section done and be sure before you proceed with a radical removal. But even other many conditions have been described of liver, heart, and lungs, which will cause the elevation of the CA125. And of course, the non-gynec malignancies, once they are metastasizing, they are all responsible. So there was a huge trial which was tried regarding the UKC TOX trial, we call it, which was for screening, excuse me, ovarian cancer based on CA125 and ultrasound done regularly, 3 to 4 months intervals. And it was seen that it is not really recommended among asymptomatic women, because while there were some who got diagnosed early, but there were also situations where they were elevated CA125 and they were not ovarian cancer, and the surgery resulted in serious complications, as we know all surgeries can. So the benefit risk did not work out clearly. And what has been seen is that more important is the change in sequential measurements. Not only during in the screening also they saw one patient who had a CA125 of 10. 3-4 months later on the next one, a CA125 was 25. Now it is still within the range, but it has gone 2.5 times. That patient had a stage 1 ovarian cancer. Similarly, the change in sequential treatment measurements when you are following up later also as a prognostic is more important. It's another matter that these days we say that just because of a biochemical, we should not immediately initiate any treatments. So it's an important tool that in our hand for monitoring. And the other thing is that you have to see other parameters sometimes. Now, suppose we have a CA, what is the usual level in ovarian cancer of CA125? More than 35. But CEA should be less than 5. And the ratio of CA125 to CEA should be more than 25. So herein comes the role of GI endoscopy. It's not to be done in all cases. It's not required. But the upper lower GI may be required if there are GI symptoms, even though we have said that these are the ones which are more common. So all patients may or may not have, so you have to see. But if these tumor markers are showing CEA to be more, then you have to consider doing the endoscopy. And now we have HE4, although we don't do it as a routine, but this is an option when required. It's overexpressed in the serous and the endometrioid. Normal range is 60 to 150 picomole. And you do get false positives in renal failure cases. It's more specific and sensitive. It's not elevated in endometriosis. So this is one important factor here. So it can be considered for the differential diagnosis, especially in the premenopausal patients. Now, this is an age-old chart which is going on, so don't need to dwell on it, but the germ cell tumors are so good in providing us with the biomarkers, which really help us to categorize preoperatively which tumor we have. And as I said, the majority of them will be chemosensitive. So in all women under 40 with a complex ovarian mass, please do these markers to rule out the germ cell tumors. Now, multimodal tests, you have ROMA, risk of malignancy algorithm, which they made with CA125, HE4 and menopausal status and gave the cutoffs. But this is a paid algorithm. They charge you to do this calculation. And it is based on data from not our population, but this UK and all population. So it's not really quite suitable for us. Similarly, now you have the GOF triple screen. It's positive if 2 out of 3 are positive. Here they have added to the symptom index, the CA125 and the HE4. Then you have the Copenhagen index, CPHI. So here also the same parameters with age have been taken. Then you have OVA and OVERA. Here they have gone a little more detailed. It's the first generation OVA multivariate index assay, and the OVERA is the second generation multivariate and assay, and they have included a lot of molecules, transferrin, epolipoprotein, transithin, beta-2 microglobulin, and then in Overa they went further and they added on some FSH levels, etc. So the cutoff varies in OVA for premenopausal and postmenopausal 5 and 4.4, in Overa only 5. But we see good sensitivity and specificity has improved with the Overa. So as more and more markers are coming, more and more multi-marker tests are emerging, and they will in time perhaps be the routine. But apart from the ultrasound, we have other modalities, CT scan, MRI, PET-CT, routine for us now. So CT scan is good, more widely available, relatively low cost, and it can evaluate the abdominal metastasis, detecting peritoneal implants, pelvic lymphadenopathy, obstructive uropathy. But the assessment of the ovarian internal morphology is not as good. So MRI is better as for that, to characterize the internal morphology. And it is, if there's masses which are less than 5 centimeters, we say they are usually benign. If they are more than 10 centimeters, we say they are usually malignant for reproductive age group, I'm saying. But where they are 5 to 10 is where they are gray zone, and you have to decide which bucket will you go into. So where there's an excel mass more than 7, the MRI is very helpful. PET-CT is not required for evaluation in the preoperative phase. So the problems now with CT scan, it cannot tell you the fine nodule carcinomatosis. And MRI is more reserved for those young women who will require the fertility preservation. So this is a summary which is available from the ASCO resource stratified guideline. And I brought this because I think this is very useful. ASCO in there has various resource stratified guidelines in which they call it as basic, limited, enhanced, and maximal settings. So basic is probably just too basic for this scenario. Limited, I will call a small nursing home. And maximal, I will say, is the tertiary center cancer hospital, and the extended is somewhere in between. So now if you are in any of these, limited, I think, is the most important, as I'm saying again and again, to decide. You keep the patient with you and call somebody which at least makes you an extended, or you send the patient to the extended or maximal. So here you can see what all facilities will be available to you, and referral for staging surgery is recommended for the basic and limited. Metastatic workup can be done in limited, and extending and staging can be done by the extended. Maximal is not necessarily always needed. Now, peritoneal cancer index is something we use routinely, the PCI, when we are doing the surgery, to see when we do the staging laparotomy, and these various quadrants are marked out and to describe what is where. But the similar scoring can be done by the good radiological assessment to give you a feel of how it will be when you open. And so these are the various anatomic structures that are listed and are looked at. But people have also looked at laparoscopy. One of the earliest was Fagotti, who made a laparoscopy-based score. So he said, don't go in necessarily. First, put in the scope and see, is there peritoneal carcinomatosis, diaphragmatic disease, mesenteric disease, omental disease, bowel infiltration, stomach infiltration, liver metastasis, and give a score of 0 or 2 based on whether these are present or not. And then decide, if you don't think you can resect it completely, don't do the surgery, close it, give her the neoadjuvant chemotherapy, and call her back after 3 cycles to do it after that. Because the likelihood of a patient having suboptimal surgical result is 100% if the predictive index value, what you get by the scoring system, is more than 8 or more than 8, then it is probably better to abandon it. So this, some people argue that it should be a part of the care as a routine, because then no unnecessary laparotomy, then patient has to first recover, then you will give the chemotherapy. So some time is lost. Plus, it gives you an opportunity to collect the tissue for definite diagnosis. Of course, if you're going for NACT, you do have to have the definite diagnosis, which you can take by image-guided biopsy. Usually, we will do it from the omental mass or something. So, overall accuracy rate has been described as 90%. So now, aspiration and biopsy. If we know we are going to do surgery, we don't encourage that we should do ascitic taps and biopsies, because we have seen deposits in abdominal wall by the tumor up spillage and possible upstaging if you are going to go into the mass. But if it is required for NSCT, definitely, and the image-guided needle biopsy is like the minimally invasive method here. It is safe and effective, and you can get the high yield and accuracy, etc. So the preoperative assessment talk will be incomplete without just emphasizing this one slide, that perioperative care is essential for the overall safety and high quality, and the pre-op assessment should include frailty assessment and rehabilitation introduction, a screening for anemia, because in these cases, poor tolerance to oral iron is common. You may require IV iron. Hypoalbuminemia correction is very important, because what does a wound need for healing? The wound needs good carriage of oxygen, good carriage of all the nutrient factors. So I always say that there should be good hemoglobin, good albumin, good vitamins. That's the way for a wound to recover. But albumin is also very important to the anesthetist, because albumin is what most of the anesthetic drugs are carried on. So you need all these to be in order, and the fitness. And if you're going to do any fertility sparing approach, frozen section or completion surgeries, consent is very important. You can't do anything without consent. And frankly, in ASA grade 1 patients, no anesthetic complications. Better to do stepwise. If you have not taken the consent, then do it as a second surgery. And the plan for post-operative care also, again, ERAS is a different topic, enhanced recovery after surgery. But that also needs to be discussed, whether you're going to go the routine pathway or the ERAS pathway, in which way you will do it. So in conclusion, I will say early identification of benign versus malignant adnexal masses is paramount for determining your outcomes. Imaging used in conjunction with tumor markers is essential. We have risk tools now, RMI, IOTA, ADNEX, and they give a good scoring triage up to 80% of cases. The nature and order of testing is usually dictated by cost and resource availability, and the surgical interventions are guided by the nature of the adnexal mass. So thank you very much, and please use the rest of this month to spread awareness of ovarian cancer to all your patients. Thank you for the invitation to be here today.
Thank you, Dr. Nirja Bhatla. I mean, I must say, I'm a benign surgeon, okay? So I simply feel this deliberation on pre-surgical planning of ovarian masses was fantastic, in spite of your health issues, And I wish I had got this to, for my PG students to listen to also. I mean, that's my mistake. I missed out on that. And the term that I liked the best, was that ovarian carcinoma whispering. I mean, it means so much, and it holds so much in it. And I myself, sometime back, we saw a case. It was about 14 weeks, I think, ovarian. CA-125 was 120 or so. Okay. And as usual, we did everything. Lag raha tha, this is endometriosis. Nothing else is positive except CA-125. And of course, back to Dr. Giri, I called him up, sir, aisa sora kya karne ka, meko to endometriosis lag raha. One of the dilemmas that I'm sharing, ultimately we did it. It came out to be endometriosis. But I love the way you said we should do the RMI1, the IOTA rules, and the IOTA adnexal model. Thank you so much for enlightening all of us. Over to the organizers.
Yeah, Madam, it was a really very excellent presentation. Recently, I attended a oncology conference. It was an international oncology conference. Madam, I must say it is beyond compare. You are a gynecologist, but it is far excellent. Thank you, Madam. Thank you so much. It's for an excellent presentation, Madam.
Thank you. Thank you very much. I see one question in the Q&A box, but I think we have sort of answered it. No, it just says USG benign and malignant. So I think we have explained this already, right?
Yeah. It used to be so scary to talk about the ovarian malignancies.
Huh?
And, people have been, there have been times when we could only diagnose them once they come to us in stage 3 or 4. Much later than we could, and today you gave a very, very important word, that they whisper. So that is a very beautiful word, that we must listen to all the whispers which come to us. And more important thing is that we do not even put our hands on the patient's abdomen, do a per vaginum examination, which is so essential, you know. That is where we miss. We straight away send the patient for investigation. The clinical examination is somehow being missed nowadays. That is my, uptake. I have seen the youngsters how they go about it. They do not give any value per se to the clinical examination, which is so important. And stressing on the need of clinical examination, I think we must always continue for that matter, because that it is very important, the clinical examination part.
Very
And we must listen to all the whispers which we get, because I have seen my close friends, mother and relatives, they suffering, being diagnosed very late. But that is where, you want to talk more about it, know more about it. The more you know, you feel the little you know. So your oration today is, I think, epic of all the confusions which we have about this malignancy. Anjana, you wanted to talk something.
No, I would just want to thank Dr. Nirja.
Could I
Ma'am
just
is a
ask one
pioneer.
more question here? Dr.
Yes, sure.
Nirja, in the ORADs, they write that simple cyst up to 10 centimeters. So what is your this thing? Should we interfere or should we not interfere? Because till now we have been studying that up till 7 centimeters is fine, but ORAD says it's up to 10 centimeters. So what do we do there?
Like I said, between 5 and 10, you will often find that there are, it's confusing which bucket they go to, and more than 7, definitely you have to see. But if it is just a simple cyst and nothing else is there, then definitely then you can rest assured that this could be a benign one and keep it on the follow-up.
But do we wait for regression, or if it says of the same size, if it doesn't regress, then better to interfere?
Yeah, then you can go in for a laparoscopic procedure, definitely, depending
Yes.
on where those cysts are coming from. And sometimes they are paratubal cysts, sometimes they are ovarian cysts, and sometimes then there is a risk of torsion also. So if it is all benign, then you can very comfortably, a 10 centimeter cyst, go in laparoscopically and get it off.
Yeah. So intervention is better.
Yes, I would say
But
after.
madam, excuse me. In medical, we can do medical management also in simple cyst,
So you know what the
gynecologists and
many people give the oral contraceptives for suppression and things like that, but they
and
actually
results are also good, madam.
anything for the current cyst. But if somebody has a liability to get these cysts repeatedly and they are follicular cysts, then definitely it will prevent the recurrence. But this cyst, if it has settled on its own and not because of the OCPs.
Madam, it was an
All
excellent lecture.
Can I ask something to the organizers, please? Just a question.
Yes.
I mean, we name it as an oration. So, I mean, we are happy when people interact, but do we allow questions in an oration?
Yeah, I think
Do not allow,
but I think we should, I think we should, because when we get people like Dr. Nirja, we need to discuss things across the internet, I would say.
These are not.
Madam, we should.
Otherwise,
Dr. Nirja is there, we can break the rules.
Yes, we will break the rules in this case. Definitely. Now, along those lines, Dr. Nirja, what I was just saying was this question which came up on on the use of OC pills and those small tumors. Are you getting me, Dr. Nirja?
yes.
Okay. So many a time in our teaching programs also, it is often said in most books that if they are kind of functional ones and between 8, 9, 10 centimeters, we could try, having ruled out and done all the tumor markers, we could try 3 months of OC pills. Is it still advocated or you have another thought to it?
So my thing is that you can wait for 3 months without OC pills. If it is
rather not give them, because anyways we are feeding them with hormones.
There are
additionally.
some patients who have a propensity and they come back again. If that is
Yeah.
your patient, then definitely give OCPs. Then next one will not come. But this
One should not. Yeah. Okay.
intervention only. So I have a question for organizers also. What do you do with the recordings?
We put them on our channel, YouTube channel.
The answer for the person
Excellent.
that they've joined late.
Excellent.
So we
See
put
that.
all the recordings on our YouTube channel.
Great. So that is where you have to go and you will see it all. And the chronic corpus luteal cyst also. Really speaking, I mean, most of them are eventually going to settle. And we don't really need to do much in terms of interfering for a corpus luteum cyst.
Okay, so thank you so much, Nirja ma'am. Myself, Dr. Priyanka from Jaipur. It was such a wonderful session, ma'am. You have, cleared all the doubts, and myself is doing onco surgeries, and it was such a pleasure to listen to you on such a platform. Thank you so much, and we would like to, hear you from you again. And I would like to thank the chairpersons also for joining the session. Thank you, Anju Soni ma'am. Thank you so much for such a wonderful session. It was really an eye-opener and a great learning opportunity for us. Thank you so much, ma'am. I would like to request Anju Soni ma'am to further add something to this session and say something.
I would really like to thank Dr. Nirja for taking our time for, because this session we are focusing so much and it's only 1 hour that I've been behind her for so many days that you have to come and talk about this.
Yes,
So
ma'am, definitely.
And I would also like to thank Dr. Sujata and Dr. Sarita for being here, because we really need people who are seniors and who can give their, practice experiences.
Yes, ma'am, definitely. We youngsters learn from you seniors only, and we are trying to, walk on your steps and learn from you all.
Thank
you
you
so much.